webinar, we will be focusing on the intersection of blockchain and social determinants of health, SDOH. I'm Krista McFarland, the president of the board of the association. The Patient Tory Association was incorporated as a global nonprofit healthcare member organization in order to meet the need and facilitation of the adoption of emerging technologies in the healthcare industry. We provide educational content and events, most commonly our Block Health Summit, which launched in 2018 and now partners with the Dubai Smart City government in an annual conference on promoting the advancement of blockchain in healthcare. Currently, the association connects healthcare industry adopters of the P2 network blockchain. The P2 network blockchain securely stores and manages health information in real time, and such storage and management is facilitated by the blockchain-based token called P2, the world's first healthcare cryptocurrency. The goal of today's webinar, we can move to the next slide, will be to assess new technologies and standards that will drive interoperability, extensibility, and scale for integration of social determinants of health as relates into patient care. We'll also analyze current challenges to accessing social determinants of health data, identify opportunities for patient populations, and the role of predictive data risk management on improving care. And not only that, we welcome your feedback and would like for you to ask questions as we debate the next wave of SDOH use cases and applications that widespread blockchain adoption can and will support. Without further ado, I would like to ask our esteemed panelists to briefly give a brief background about themselves. Starting with John Klaus.
Good morning, John here. I have a background in engineering and enterprise architecture that came from the e-commerce and supply chain, retail and philanthropy industries, and been taking that into the healthcare industry over the past 7 years, focused on data science applied to healthcare in the efforts to improve patient outcomes, reduce emergency department utilization that could be avoided, take care of readmission risk, some other things that improve the lives of patients and decrease the cost of healthcare overall.
Thank you, John. Next, we'll have Dr. Tiffany Gray. You can please introduce yourself.
Good morning, everyone. I'm Dr. Tiffany Gray. I am a public health advisor and consultant and researcher by training. My background is in health behavior as well as maternal and child health. My most recent research and work has focused on behavior centered around tobacco control, as well as addressing maternal mortality issues and challenges and initiatives, as well as various areas within blockchain space with an emphasis on addressing health disparities and population level health outcomes.
Thank you, Dr. Tiffany. And last but not least, Jonathan Fuchs.
Hello, I'm Jonathan Fuchs. I'm a member of the board of directors of the Patient Tory Association. My background is in healthcare operations in any number of different forums, be it hospitals, managed care companies, and startup operations. I currently work with a number of companies relative to data analytics, population health, as well as payment reform and in the United States.
Thank you, Jonathan, and thank you, panelists, for giving us a brief introduction into your day-to-day and your expertise. We always like to start our webinars with an introduction to blockchain, as it is still an emerging technology and many people are still catching up. The brief definition of blockchain says there's a growing list of records called blocks that are linked using cryptography. Each block contains a cryptographic hash of the previous block, a timestamp, and transaction data. And while this is true, we see blockchain transform in different industries, particularly healthcare. John, can you describe, based on this presentation, what is blockchain?
Yeah, I think if we wanted to take a move to undercomplicate this for a second, the most important thing to say is blockchain is a database. Blockchain is a little bit unique in most organizations. The database is in the center of the IT fortress. It is the most protected asset because of the information it contains. So while we're all familiar with the database, there's something novel in that blockchain is a database that's so inherently secure. Instead of having to sequester it in the middle of our organization, it can be put out on the internet. We can create multiple copies of this database. They can be located all around the world, and we have the guarantee that it is secure and safe, and that transactions between the appropriate parties have integrity and can be trusted, and that those who don't have permission to see those parts of the blockchain are not going to be able to get in, and they're not going to be able to change that data. So if we go forward a little bit, it might be useful to talk about what is it that makes the blockchain database so secure. And I think there's three main concepts that we could hit on today. One is around decentralization, distribution, and the idea of an immutable or unchangeable ledger. So if we said blockchain is just a database, it's a database with these properties that makes it unique. And we'll kind of just dive into those one at a time. If we focus on decentralized, the main idea here is that it is not controlled by one organization. So in common language, decentralized and distributed kind of have a similar connotations. But in this particular context, we're talking about ownership. So Bank of America is a single authority. They have to trust you, you have to trust them. And in the blockchain space, we're not relying on that trust, we are decentralizing. So if we go to the next concept, which is distributed, the next slide. This is really talking about location. And while many organizations may have multiple databases, the intent behind distribution in blockchain is around guaranteeing that no one's committing fraud, that transactions aren't being changed or reversed. And the way that's done here is that there's a mechanism where anyone in possession of the data can check and validate that nothing has changed. So the intent and focus behind blockchain is to distribute the data and place copies of that all around the world so that the majority can come to a consensus on what the truth is and prevent fraud. So the last piece in this idea is the immutable ledger, but let's talk about that in two parts. So on the next slide, we're going to talk about, we can move past that. There's some interesting examples there of the difference between distributed, decentralized, and the combinations thereof. But let's dive into the immutable ledger part on the next slide. Here we go. In this case, we could use the word database in exchange with the word ledger in terms of what we're doing. In Bitcoin or in cryptocurrency, we're storing transactions of a financial nature. We could just as well be recording supply chain information for product moving throughout the world. It could be real estate title, or it could be parts of the electronic health record. And the first concept we'll introduce here is that data is stored not in one single monolithic file, but in blocks. So we'll collect a number of transactions and we'll fill up that block. And then when that block's full, we'll create another block. And then we'll start collecting transactions in there. So that's established the idea of a ledger, but we need to go one step further. In the case of blockchain, there's a guarantee that transactions can't be changed after the fact. So there's a process here where we start with a block, we create a unique fingerprint for that block. And that it's the case that you can't change a single decimal point in block one without changing its signature. So that gives us an identifier for that single block, and we'll use that to start the next block. We'll collect some more transactions, and then we'll create a signature for block number 2, and we'll repeat that process. And so this is where the name blockchain comes from, and this is what imparts that immutable quality to the database that is blockchain. There's no way you can change one transaction without changing the fingerprint for that block, in which case the next block and its fingerprint would not match up. And so that fraudulent version of the blockchain, or that erroneous version of blockchain, would be rejected because it didn't match the technical criteria that blockchain enforces. So between decentralizing and making sure that multiple parties share control, or no one party has control, distributing so there are multiple copies of that, and this blockchain immutable ledger concept, we now have a database that doesn't rely on trusting one authority, and that doesn't have to be sequestered inside the firewall of an organization, that is inherently secure, and then it can be placed out on the internet to be used by multiple organizations. So I think we have one more slide here to kind of round out an overview of blockchain. In terms of just kind of putting all of these pieces together, let's take a look at the next slide. So this is kind of a different take on it. We've assumed we have a blockchain that's a decentralized, distributed, immutable ledger. As someone trying to use that, we have an application, we have a wallet, we have some kind of interface to the blockchain, and we want our transaction or our health information or our supply chain information to be recorded on the blockchain. So our client broadcasts that transaction out to the blockchain network. Any node on that network that is processing transactions will listen to that. It's collecting these transactions, and it's using a consensus mechanism to determine which transactions are going to be added to the block, and then which blocks are going to be propagated as the official version of the blockchain. That consensus mechanism is very, very interesting, probably content for another day. And we could spend 20 minutes on that. But the consensus is the key to the public blockchain network. And once that transaction is recorded in a block, that block is added to the chain, and that version of the chain is then synced up across all the nodes in the network. And then we have a permanent immutable record of that transaction and all the transactions that preceded it. So that's a very quick, a high-level overview. I think the key takeaways here are that blockchain is a database, and it's a database designed in such a way that it doesn't rely on trust and being sequestered behind a firewall to allow multiple parties to securely and confidently interact with data.
Thank you, John, for that wonderful overview. This is definitely great and in-depth information. Moving to our next slide, we'll be tackling social determinants of health. Public health reports currently define social determinants of health, also known as SDOH, as the economic and social conditions that influence individual and group differences in health status. So, Tiffany and Jonathan, can you guys briefly describe social determinants of health and how you've encountered it in your career or in your expertise, both on the research, Tiffany, and in industry, Jonathan?
So when we talk about social determinants of health, as Krista mentioned, we think of that within public health as, again, sort of those conditions within one's environment or the various environments in which people, are born into, in which we live, work, play, worship, as well as factors such as our age, and how those impact quality of life outcomes and our risk for disease and for prevention. So we think about the social, economic, and physical in these various settings and how that plays into, again, how that impacts overall health outcomes. So some examples include such availability of the resources to meet one's daily needs. So we can think of that as housing, access to food, as well as our educational levels of education and how that then further influences our economic and job opportunities and wealth status. And then we can think of access to health services and other community-based resources, even things such as transportation and public safety, social support, and also other factors that influence that include social norms and attitudes. So the things that we sort of encounter on a day-to-day basis, including discrimination and racism, and even at the policy level. And then we can move into the examples of physical determinants, which include more of our natural environment, such as availability to green space. And when we talk about, whether you believe it or not, climate change, built environments such as our buildings and the access to roads and bike lanes and our work sites and housing. So all of these different factors play into how we sort of are able to engage and engage with healthcare, and sort of, again, our susceptibility, to disease and health outcomes as well. And so in my line of work on a day-to-day, when we think about, say, addressing health behaviors, it's not enough to just think about the individual or the factors at the individual level, but also sort of these other factors and how they play into whether individuals are able to engage with healthcare systems or how they utilize healthcare systems. If you don't have access to health insurance, that's based on, say, your education level, or that's based on the job opportunities that you have, whether or not that's provided through your current system of employment. These are all factors that play into whether or not you're going to follow a treatment plan, for example. Or was having a discussion the other day about if a individual presents to a provider and they have high blood pressure, for example, and they've been prescribed a certain treatment plan. They come back and follow up, say, in a month or two, and the doctor asks whether or not an individual has had any change have they been adhering to their treatment plan because their pressure levels haven't dropped. The individual can say that, yes, I've been taking the medication that's prescribed 2 times a day. If I were to go off based on that information, just based on that pressure number, it's, well, clearly you haven't been adhering or taking your medication. Well, if you were to talk to the individual, it's, I'm taking it 2 twice a day, but was it based on how they were perceiving how the instructions? It's actually, you're supposed to be taking the medication 12 hours apart. So you're taking it, to the individual, they're taking it at 8 a.m. and they're taking it at 10 a.m. whereas they're supposed to be taking it at different intervals. Or I'm prescribing a certain medication and certain side effects can impact outcomes as well. And you have a bus driver who's not able to stop all the time because of the requirements of their job. That's going to impact treatment outcomes. So there are modifiable factors and non-modifiable factors that we have to take into account when we're talking about addressing social determinants of health and health and disease.
Thank you, Tiffany. Jonathan, do you want to follow on with any additional information? Oops, I believe you are still on mute, Jonathan.
I'm sorry. There you go. Sorry. I think this blockchain could become prominent in the healthcare industry. One of the intractable problems that we have in terms of electronic healthcare activity is the issue of interoperability. So blockchain offers a means to interoperate, since all users of a network can access that network, and all pieces of information are verified and show the history of transactions, which is the hallmark of blockchain in the beginning. And also, it has an opportunity in terms of healthcare technology innovation as relates to payments and payer contracts. When a health plan and a patient are dealing with a contract, the blockchain can verify and authorize information in the contractual process in a trustful manner. And so there's little haggling between the health plan and the provider and what's to be paid, why it was paid, whether it should have been paid. Transparency and automation creates greater efficiencies, which theoretically will lead to lower administration, faster claims, and less money thrown out the window. But I think another potential application is in terms of data analytics and population health. So instead of relying on health information exchanges or other ways to aggregate data, organizations can eliminate the so-called middleman and access patient databases on a large population scale. Spending time and resources verifying members' trustworthiness, that is health information exchange or payer claims databases, local EMRs, it doesn't make sense in the long term. And blockchain can leapfrog that population health by providing trust where none exists, for continuous access to patient records by directly linking information to clinical and financial outcomes. And those are just, I think, some of the great opportunities that this has. As in terms of the United States, our payment reform is moving to a value-based mechanism where it's not simply fee for service, but an overall patient's experience and overall patient's care are going to be tied to reimbursement, and the importance of incorporating social determinants of health into the blockchain component is going to be critical, because social determinants of health are really going to become, as Tiffany clearly stated, a clinical manifestation of the patient's well-being.
Thank you, Jonathan. In our next section of our presentation, I'll open it up to our panelists. Can you provide any current events or any insights as to why social determinants of health is such a timely topic? And then, you know, with hot technologies such as blockchain, why is this integration so pivotal? We can start with John.
Yeah, I think in terms of timeliness, looking at the cost of healthcare and there are specific populations. So if we focus on the Medicaid population in particular, the impact of social determinants of health has an outsized effect on members of the Medicaid population. So it's something where if we knew a little bit more about those social determinants, the socioeconomic status, the ability to focus the right resources, provide things like transportation vouchers, so that someone without a car could get a ride to the primary care doctor instead of them waiting until the situation has become more urgent, and now it's an ambulance ride to the emergency department. So that's not the best care for the patient, and it's a lot more expensive care in terms of the overall cost to the system. So the benefit isn't going to the patient, it is excess money being spent, a worse outcome. No one wants to go to the hospital. So Medicaid is an inherently decentralized system. It's decentralized to the states. Inside of each state, there's often more decentralization to regions or to groups of providers and networks. And so there is the potential for an intersection of social determinants of health and a blockchain style solution to be able to start to manage that information. And it can be as simple as something like the Meals on Wheels program, where the average Medicare patient may only see a provider once or twice a year. And potentially, if they're lucky, they might have a social worker encounter on a monthly basis. But Meals on Wheels is seeing that person every day. And there's information on those social determinants. So has their social environment changed? Are they no longer socially engaged? Do they live alone? Has the front step changed, so they now can't walk out in their neighborhood, or they're not making healthy food choices or they're not eating? Those pieces of the social determinants of health, there's no way to record them in a current electronic medical record. And so it is a main driver of bad outcomes, a driver of cost, and something that I think we're starting to recognize more and more. It's not just clinical measures, but it's social measures that are going to be required to address the healthcare need.
Thank you, John. Tiffany or Jonathan, would you like to follow on with that?
Well, I would echo John's comment. I think social determinants of health plays a significant role in the success of value-based contracts, as I mentioned before. Healthcare costs continue to rise. Organizations must recognize the efficiency associated with understanding the needs of their populations beyond simply clinical data, and the importance of gathering and reporting the data across the entire care continuum. And I think that's really the hallmark of what SDOH and blockchain can achieve.
And expanding upon both what John and Jonathan just mentioned, is by having those, especially in public health and in public health systems, having that information is crucial. It also can help us to better inform the types of policy and really have an impact on policy level change by having clear measures of how these factors are changing and how health outcomes are being impacted in certain populations. And I'd also address that having a tool such as blockchain and other emerging technology being integrated into health and addressing social determinants of health helps us to deliver a better system of care, and it can help us to better engage with patients and individuals and meet them where they are. I think that's key here, is talking about lack of access or in rural areas, for example, and even on the provider side, addressing the issues of capacity and having the capacity to be able to reach individuals. It can allow for things or expansion of things such as telemedicine or telehealth, and development of mobile application tools, and improving, even addressing issues such as language and literacy through this technology to better improve health and health outcomes.
Thank you, Tiffany. I know we have about 60 seconds left with our presentation, and I wanted to follow up with additional, potential use cases for the integration of blockchain and SDOH. I know Jonathan and John, you guys mentioned a few, such as Meals on Wheels. If you have any other ideas, feel free to share. And adoption. What are some current regulations that are currently being enacted or being debated today that may affect how SDOH is integrated into healthcare practice?
Well, I'll answer one. I'll start one as a concern, is that not all of the agencies that are in the SDOH sphere are on an electronic record of some sort. And so the ability to get data and information into a blockchain and continuum is going to be a challenge for institutions and ecosystems unless they find some way of finding how the data can get into the system.
Thank you, Jonathan. Tiffany or John, would you like to contribute?
Yeah, I think in terms of blockchain and healthcare, there's a couple different areas that are getting some attention. So certainly social determinants of health is an interesting one. Registries of providers. Who are the providers in a state? What's their certification? What's their specialty? And maybe even what's their availability? Are another area where there's no centralized agency to keep track of that, and a decentralized blockchain solution has gotten traction. There's a number of insurers, provider groups that are working on that. I think, as Jonathan said, in the social determinant of health space, many of the participants don't have an electronic record, and many participants are solving this kind of in a siloed approach. So their first initiative is to track social determinants inside of their network, and that's inherently limited. It's a step forward, and I'm hoping that we'll see, whether it's through blockchain or some other mechanism, a way of looking across networks, across individual systems or insurers to kind of find a holistic way of addressing the needs of those populations.
And there's one other thing. Many of these agencies provide services that are not, quote, reimbursable by traditional insurance means. I think that's changing due to the issue of value-based payment and overall patient wellness and how that's going to be calculated going forward, both by Medicare and private insurers. But in the short term, that could prove to be a bit of a conundrum, so to speak.
That's great information. So with our panelists, in leaving our attendees with a couple of, words, where do you see SDOH really taking off in 2020?
Jonathan, I don't think there's any doubt that SDOH is the buzzword of the week relative to healthcare. I was joking with Tiffany earlier on in a previous conversation, is that the public health people are laughing all the way to the bank because they've been promoting for 100 years, and suddenly it becomes fashionable under a new title. But it's clear that people recognize that these issues have to be incorporated into the healthcare ecosystem in a more formalized way.
And I definitely echo Jonathan on that point. It is definitely one of those key buzzwords that's being mentioned a lot in the space, and specifically in blockchain and in other areas. And when we're
I think we may have lost you for a bit, Tiffany. Are you still there?
Hello?
There you are. Yeah.
Okay, sorry about that.
Lost you. If you can
sorry.
just repeat yourself.
I was just saying I would definitely echo Jonathan's point of social determinants of health is definitely a big buzzword, along with things like systems thinking and innovation. And I think everyone, especially in public health, is eager to start addressing issues of health and health equity through other means. And technology is one way that we are beginning to examine how we can sort of begin to address some of our lingering issues, our persisting issues. But I always remind everyone that, blockchain is a tool and a resource. It's just one tool or resource that we can use to start changing some of these systems. And at the end of the day, it's very important as we are developing these applications or these tools or integrating the technology in various systems to really make sure that it is an inclusive process, that we are including individuals in understanding their key needs and what's important to them, and what are some of the barriers to utilizing some of these tools and resources. And again, it's very important to begin also thinking about the key pieces of policy and regulation and ethics or ethical regulations that will need to start being put into place, or start having those conversations of what that looks like as the technology continues to move forward. As we know, technology tends to move a lot faster, or advancements move faster than some of these policies and regulations. So it's important to begin really having those key discussions and think about what that may look like moving forward.
Thank you, Tiffany. And John?
I think I don't know if it's 2020 or not, but just to kind of bring together Tiffany and Jonathan's points, like getting traction and producing some tangible results, it really will be key from being a buzzword to incorporating this as just an integrated part of healthcare. So that whether it's 2020 or a little bit beyond is really something I'm looking forward to.
Thank you, John. We have a question from our attendee. This came in from Edward Clinton Klein. Oh, it's actually in reference to the association. So he writes, I'm still trying to understand the overall goal of the Patient-Tory Association. Is the primary goal simply to provide a decentralized database of patient care records accessible by anyone in the world, all providers and patients, or is it more than that? So I can actually take this one. And Jonathan, who is also a board member, please feel free to follow on with any additions that I may have left out. So in our introduction in today's webinar, I introduced the Patient-Tory Association as a nonprofit healthcare member organization, which facilitates the adoption of emerging technologies in the healthcare industry. Right now, the mission of the association is focused on blockchain and decentralized database DLT adoption in the healthcare industry, for which it promotes the PCOINet blockchain network, which, yes, it is a network that is focused on providing a decentralized database of patient care records, which is both medical and healthcare data, accessible to primarily the patients first, who have access and ownership to their information, but can also be easily accessed by industry as well. So yes, blockchain is a core focus of the association right now. It drives a lot of our webinar content and summit content and planning. So that is true. But it is more than that, in that it is a industry trade organization where we are focused on emerging technologies, so VR, machine learning, or other types of technologies the association promotes, but it also promotes the collaboration of industry, whether that's payer, provider, to innovate and find new ways of providing more meaningful and, of course, cost-efficient healthcare for society globally. And with that, I would like to thank our panelists for participation. Jonathan Fuchs, who sits on our board, Dr. Tiffany Gray, who has been a tremendous contributor to our peer-reviewed journal, especially in the topic of social determinants of health, and John Klaus, our partner under the Patient-Tory Inc. partner under the Oregon Enterprise Blockchain Venture Studio, and where we are currently researching and assessing the implementation of this in practice. And John, do you want to add anything about this particular project?
I think in terms of looking across some local opportunities in healthcare, using blockchain not only as a potential solution, but as a way of drawing attention to the need to move forward and get traction with social determinants of health. This has been a great exercise, and in the end, it's getting this information to help manage patients, to build data models that help identify risks that we're not seeing right now, and directing care to the most appropriate places. So it's the Oregon Enterprise Blockchain Venture Studio and the Patientory engagement with Moda Health has been fabulous.
Thank you, John. Any other last words from our panelists before we end our webinar today? All right, with that, I would like to conclude our second webinar and final webinar for 2019. And we look forward to having you join our next webinar in our first quarter, the new decade in 2020. Thank you and happy holidays.
Same to you. Thank you very much.
Thank you.
Cheers. Happy holidays.